Okay, we're going to get started. Thank you guys for coming. We understand with UN Week that some of the roads have been closed and we're getting texts that are stuck in traffic, so congratulations for those of you who made it here. Others will be joining. We have a really strong attendance, so I'm grateful to be able to kick this off. My name is Stacy Limborg. I am CEO and President of Imunon, and to our colleagues that are online, we had really an outpouring of interest in this event. We're thrilled by that, and it's my honor really to get to welcome our esteemed guests, investors, and partners. We have really a collective commitment. That's how I interpret the interest, even in the first day that we issued the release. It's very clear that there is a keen interest in Imunon's ambitious goal, which is to revolutionize the standard of care for women battling ovarian cancer. So over the next 2 hours, we're going to dive deep into the realm of ovarian cancer research, guided by experts who have devoted their careers to combating this formidable disease. And together, we will envision a future where we can significantly impact the lives of those affected by this aggressive and very often fatal illness. Before we proceed, and I'll keep my comments short because you came to hear the people who are sitting here on the front row, it's important to set context and really two really important points. Number one, the standard of care in ovarian cancer has remained largely unchanged for the past 25 years. And until very recently, no trial in ovarian cancer has demonstrated an overall survival benefit, including the historical trials that set the current standard of care for first-line treatment. So today, you'll discover that we're standing on the brink of a new era in ovarian cancer treatment, and Imunon has already achieved a feat by being the first to show an improvement in overall survival with Imunon 001 by extending life for nearly a year over the standard of care. This milestone really propels us as a company to other groundbreaking achievements, including perhaps Imunon 001 is the first immunotherapy to be approved in ovarian cancer. It could also be the first product to effectively harness IL-12 for therapeutic benefit, which would be transformative well beyond ovarian cancer. So why am I confident as CEO in Imunon's potential for success? It really is very simple. We've demonstrated a method to safely deliver sustained levels of IL-12 directly into the microtumor environment. Our clinical data not only supports, but strongly suggests that Imunon 001 offers a long-term benefit in overall survival. Moreover, we're working with an exceptional team of physicians, and we have dedicated Imunon employees all united in our quest to turn these potential first into reality. So without further ado, let me introduce our distinguished faculty who will share their insights and expertise in this journey, which we believe will be transformative. So they're all incredibly accomplished. I have to accomplish my introduction in 10 minutes total. So I have had to pick and choose, but I think you'll be impressed by everything that I'm describing. So first up, Dr. Sid Kirkar will be talking about the importance of IL-12 in cancer. Dr. Kirkar is a distinguished physician scientist with extensive training in tumor immunology, pathology, and surgical oncology from the National Cancer Institute and NIH, working under pioneers like Dr. Steven Rosenberg and Nicholas Rustafo. He pioneered genetic engineering of T cells to secrete IL-12, significantly advancing cancer immunotherapy, for which he has received multiple prestigious awards. After his academic career, Dr. Kirkar transitioned into the biotech and pharmaceutical industries, holding several high-level positions, and he remains active in many different aspects if you look at his profile online, including serving as the senior review editor of T-cell biology for Frontiers in Immunology, and recently launched his own consulting company, Kirkar Consulting. So next and following him will be our Chief Scientific Officer, Dr. Khurshid Anwar, who will be introducing us to the TheraPlas technology and providing an overview to this important platform. Dr. Anwar serves as Executive Vice President and Chief Scientific Officer at Imunon, where he has contributed in immeasurable and innumerable ways since 2014, which followed a role before that as President and Chief Scientific Officer at Egen. And with 30 years in gene-based therapeutics, he has developed multiple technology platforms, holds numerous patents, and has secured significant funding in both private and governmental sources. Dr. Anwar has co-authored and has published more than 50 scientific publications and is involved in various scientific communities and has been a key figure in biotechnology associations and academic programs. Next up will be Dr. William Bradley, who will be walking through the safety and efficacy of Imunon 001, focusing on the most recently read out phase 2 Ovation 2 data. Dr. William Bradley is a professor and director of clinical research in the Department of Obstetrics and Gynecology at the Medical College of Wisconsin. Since 2008, he has focused on advancing clinical care for gynecological cancer patients through research, and he has led his division to full gynecologic oncology group membership, significantly boosting trial enrollment. Dr. Bradley serves on the NCI's NRG oncology committees for phase 1 and developmental therapeutics, enhancing access to early phase trials. He advises on industry trials, has authored numerous publications and presented at major conferences such as ASCO, and currently he chairs the MCW Cancer Center Scientific Review Committee, where he is involved in key grants and trials, including the Ovation studies, aiming at the end of the day to innovate gynecologic cancer treatments. Next is Dr. L.J. Wei from Harvard School of Public Health. He will be walking through methodology he's pioneered and published that really describes a totality of treatment effect and a clinically interpretable endpoint. Dr. Wei is a distinguished professor at the Biostatistics Department at Harvard University, and he's really known for groundbreaking work in clinical trial methodologies. His career spans multiple top institutions focusing on designing, monitoring, and analyzing clinical studies, and he has developed innovative statistical tools widely used in clinical practice today, highly relevant, and earning him the Wald Medal in 2009 from the American Statistical Association, a very prestigious award. He's a fellow of 2 major statistical organizations and has over 270 publications, and it, frankly, has been pivotal in advancing personalized medicine biomarker research. His mentorship legacy is marked by the establishment of the Wei Family Scholarship at Harvard, which was established in 2014, and he serves on various scientific, advisory, and data monitoring boards, contributing significantly to regulatory science in pharmaceuticals and medical devices. The last 2 that I have for this amazing panel, Dr. Amir Daziri will be talking about the MRD trial importance and early translational insights. Dr. Daziri is the David Gershenson Distinguished Professor of Ovarian Cancer Research and the Vice Chair for Clinical Research in the Department of Gynecologic Oncology and Reproductive Medicine at the University of Texas MD Anderson Cancer Center. He also serves as the Director for the Gynecologic Cancer Immunotherapy Program and has helped establish a broad base of immune oncology program for gynecologic cancers that include adaptive cell therapies, intraperitoneal immunotherapies, and translational immunobiology. His other areas of research interest include understanding the basis for minimal residual disease in gynecological cancers and designing clinical trials to intervene during this phase of disease. And last but not least, Dr. Premal Thakur will be talking about Imunon 01 from her perspective of treating patients for more than a decade and offering perspective on what you might be missing from this most recent trial. She is the David and Lynn Distinguished Endowed Professor and Interim Chief of Gynecologic Oncology at Washington University in St. Louis, and a research member of the Seitman Cancer Center. She specializes in gynecologic oncology with a background in cancer biology from MD Anderson, focusing on angiogenesis, invasion, and the impact of behavioral factors such as stress on ovarian and endometrial cancers. Dr. Thacker leads clinical trials in novel therapeutics for gynecologic cancers, having served as national PI for several trials, including ongoing phase 1 and phase 3 studies in platinum-resistant ovarian cancer. She also directs clinical research for the Washington University Endometrial Cancer Spore. Before turning over the mic to Dr. Kirkar, one quick note of housekeeping. So due to the constraint, you're going to see we have an amazing amount of content to get through, and the desire to for inclusivity with our colleagues that are joined via webcast. We will not take live Q&A during the formal program. For in-person attendees, for those of you who registered, we will arrange short breakouts and we'll be able to have informal discussion with our presenters. And we will collect questions electronically for those of you online. If you will enter your questions into the portal, we will collect them after the webcast and we will find a way to creatively respond back to you. So with this amazing program before us, let's dive in. Dr. Kirkar.
Thank you, Stacy, for that very kind introduction. And it's an honor to be here in front of everybody to speak today about the importance of IL-12. Just really happy to be here, discuss the history, and I'll give a brief synopsis of IL-12 from a historical perspective and also from the biology. And I'll cover that in about 20 minutes, so hope I can keep everybody awake. So IL-12 has been around since 1989. And a little bit of background on immunotherapy. And these are three giants in the field of immunotherapy that I've had the fortune of working with. Dr. Steve Rosenberg, who I was a fellow with at the NCI, he really was one of the pioneers for cancer immunotherapy, developing the first FDA-approved cancer immunotherapy. And Dr. Giorgio Trinchieri, who discovered IL-12 in 1989. And that really was a cornerstone for immunology. And I'll explain over the next 15 minutes why IL-12 is so critical for an immune response against cancer. And that finding in 1989 opened the door for our understanding of how immunity works. And Dr. Nicholas Restifo, he was my mentor at NCI, and really we were the first ones to show that putting an IL-12 gene into T cells had a dramatic impact on anti-tumor immunity. So if we look at what could cause tumor regression, this statement, as far as cancer is both a genetic and immunologic disease, it would have been hotly debated 15 years ago. It was not clear that immunology played a role in cancer. But now we know, and we have credible evidence, that immunotherapy can cause every last tumor cell to disappear in certain select patients for both liquid tumors and, in some cases, solid tumors. But how does that happen? How does one person's immune system have the ability to clear tumor? It's complex. There's a lot of mechanisms that work into this. Certainly the two biggest factors that can cause tumors to regress are T cells and NK cells. Those are your effector cells, and those are the ones that we'll focus on. They're also the ones that IL-12 really plays a big role on revving those cells up to cause anti-tumor immunity. But it's complex. There's factors within the tumor microenvironment, and we'll talk a little bit about that as well. There's a lot of negative influences in the tumor against an immune response. There's also T cell factors that not all T cells are created equal, and not all NK cells are created equal, but certainly IL-12 plays a key role in making them active. And then there's host factors, and there's a lot of learnings that are happening now. Each individual is different, and each individual's immune systems are different, and understanding that and being able to predict who may respond and who will not respond is also a burgeoning field in immunotherapy right now. So I'll get a little bit into the weeds for IL-12, and I think it'll really help understand why this cytokine is so important for an anti-tumor response in immunology. So IL-12 and interferon gamma are central for both pathogens, it's called a Th1 immune response. And to understand how IL-12 works, if we take a step back, there's two major arms in immunology. There's the innate immune arm and the acquired immune arm. The innate immune arm is one that just can respond in a non-specific way to pathogens and cancer. So you've got monocytes, macrophages. These cells eat up their cells around them, and so it's non-specific. And then more recently, in the last 30 years, science has shown that you have an acquired immune system with T cells, and T cells are very specific, and they can see their target. They can look at tumors and they can see mutated neoantigens. They can see pathogens in a very specific way. So the way immunity works is different between the acquired and innate arm. And how those two worked together was not understood until IL-12 was discovered. And what IL-12 does is it's actually secreted by monocytes, by macrophages, by dendritic cells, and it acts on T cells and NK cells. So T cells and NK cells have the IL-12 receptor, and it activates NK cells and T cells to produce interferon gamma. And with that, you're getting a stimulation of your immune response, and now those T cells and NK cells can actually go and kill tumor. And what's also interesting is it's separate mechanisms. So T cells can see tumor very directly, and you can see that's in the acquired immunity. NK cells can see tumors in a different way and kills tumor in a different way. And so IL-12 works on both of them. Also, one of a key paper in 1995 by Judah Folkman, who was the father of angiogenesis, he showed that IL-12 actually has some anti-angiogenic properties. So with interferon gamma being downstream of IL-12, we now have really good evidence that neovascularization is constricted and doesn't happen in the presence of interferon gamma as much as it would if you didn't have gamma around. So what is neovascularization? That is blood vessels that are being formed. So for a cancer to grow, it has to have blood vessels. It needs a blood supply. So if those blood vessels aren't growing or they get constricted, that's a way to stop the growth of cancer. And that's what interferon gamma can do. And there's also opportunities there for combinations if you look at the different mechanisms. But certainly the anti-tumor mechanisms of IL-12 are diverse. You've got direct kill of tumor cells with T cells and NK cells, and then you've also got some anti-angiogenic properties of IL-12. Now, IL-12, discovered in 1989, as we talked about earlier, there was a rush to develop this as a drug. And so within 8 years, the recombinant IL-12 went into clinic. And there have been a multitude of trials historically. And from 1997 to 2014, 38 clinical trials have been done where systemic IL-12 was given. And unfortunately, all those trials ran into the same issues, where they had what we call CRS and cytokine response syndrome, and they had problems with liver toxicities and problems with bone marrow toxicity. A lot of that was because IL-12 was given systemically. So it makes sense because IL-12 can activate T cells and NK cells. Those cells are sitting in your lymph nodes, in your spleen, in your bone marrow. So when you get IL-12 circulating in the blood, you are going to have a lot of interferon gamma, and that can have a negative impact on patients from an adverse effect profile. It was also understood back then that mice are different. The mice immune system are different than humans. Mice can tolerate cytokines at a higher level. Humans, they have fevers. They have a different response. They can't tolerate as much cytokine. And that also is an understanding that's grown over the years. So IL-12 has been a challenge for drug developers. And over the last 25 years, we look at what has been done in the space. There's been oncolytic viruses. There's been recombinant IL-12 trying to be injected into tumors. There's microspheres. There's immunocytokines. There's liposomes. There's IL-12 secreting T cells. There's mRNA and plasmid DNA. And so this is really a game changer as far as a formula and a delivery system. And I put this quote here because I thought it was very interesting about how the field has faced the challenge. And this was a quote from AstraZeneca, from Dr. Susan Galbraith, who is a very senior management at AstraZeneca. And she says, cytokines like IL-12 are an important component of the immuno-oncology portfolio that we need to have. It's not a lack of belief in IL-12 as an important cytokine, but the mechanisms of action of those two drugs didn't meet our specified criteria. And she's referring specifically to 2 programs that AZ dropped. But the promise of IL-12 has always been there, and the understanding is how to deliver it. And this is what Imunon has really worked on and is pioneering, is the delivery system, and it's been just amazing to see. We'll get a little bit into the tumor microenvironment and why it's important to get IL-12 at the tumor site and not in your systemic circulation. IL-12 plays a critical role, as we talked about, multiple immune cells. One of the factors that we didn't understand until the last 20 years was cancer is not just a pure sheet of tumor cells. So if we look under the microscope, for many years we thought maybe what we were looking at was just all tumor cells. But it turns out that cancers are infiltrated with immune cells. And you can find every immune cell that you would normally find in a lymph node or in a spleen or bone marrow. They're sitting in solid tumors, including ovarian cancers. And what's interesting is these cells are actually supposed to be productive antigen-presenting cells. So you'll find monocyte macrophages. We call them MDSCs, myeloid-derived suppressor cells. These are cells that when they sit in a lymph node, they're good. They activate your immune system. But when they're in a tumor, they are not activated. They're shut down. In fact, they're what we call immunosuppressive, because what it does is they no longer can present antigen to T cells, and they secrete factors that shut T cells down. So the key is, how do you turn this around? How do you turn this immunosuppressive microenvironment into one that's a productive environment like a lymph node, and you can get T cells to get stimulated? The other factor that's really key to remember is that these tumors, they're infiltrated with T cells that recognize the tumor but are essentially shut down. That's what we call TIL, tumor infiltrating lymphocytes. And so if you could turn that tumor microenvironment around, you're going to be able to make those T cells that are in the tumor and that are not working to work again. And that's what IL-12 does. If you have IL-12 in the tumor, you can turn this system around and turn from an immunosuppressive to a productive antigen-presenting cell, almost like turning a tumor into a lymph node. And that's what Imunon has done. With their IL-12 program, they've been able to get IL-12 directly to the tumor site and safely allow for repeat local dosing over an extended period of time without having the systemic levels of IL-12 that you see. And here's a slide, and thank you, Khurshid, for this slide, and he's going to get into a lot of what Imunon is going to be doing later. But this is really impressive, where we could see here that with the way Imunon is delivering IL-12 and gamma to the tumor site, that you're getting IL-12 levels at the tumor site. And that's very clearly seen here in the ascites, the light blue. But in the blood, which is the dark blue, you can see the levels are very low and almost very negligible. You don't have that. And that bodes well for what may happen from a CRS perspective. And in the bottom panel there, you could see that there's also a durable expression of the cytokine with the DNA format, where after administration of the dose, you're still having expression of IL-12 8 days later. So Imunon has done something that many companies have tried and failed over the past, and that is to have reliable expression of IL-12 at the tumor site, and to turn that tumor microenvironment around with limited systemic exposure, and to induce an immune response that is something that can cause tumors to regress and prolong survival. What we also see is, from a manufacturing standpoint, that this is something that is very scalable, and that's a positive for industry. So in summary, IL-12 plays a very critical role in tumor immunology. In fact, there are many that believe that it is the central cytokine that can make tumors go away, as well because of all the downstream effects with interferon gamma. What it can do, it can reinvigorate T cells that are in the tumor. You hear this term a lot, turning cold tumor hot. Well, that's what IL-12 does. It turns cold tumors hot. And it activates and recruits new T cells and NK cells to get into the tumor, and it reverses that immune suppression. There's a very hostile environment in that tumor, and IL-12 can turn that around. And the other thing not to always remember is that there's an anti-angiogenic effect of IL-12 as well. With that, I will hand this off to Khurshid, and thank you very much.
Great talk. Good morning. Excellent talk by Dr. Karkar, and I think has made my job a bit easier to talk further about the product. So you did hear about the significance of IL-12 in immunotherapy and anti-cancer effects. I'm not going to go in detail. It's done already that. The thing was the downside of using recombinant IL-12 systemically, causing serious toxicity. Dr. Karkar mentioned about that. So we took, our task was to, how do we take benefit of IL-12 actions and properties, multiple actions, without having systemic toxicity? That's really the goal. How can we do that? And so the product that we'll hear a lot today about the clinical benefits that we have seen in our phase 2 study, perhaps try to explain to you, that lies in the design of the product. And I'll go over the design, what we intended to do to reduce safe toxicity, and what data we have to support what our hypothesis was. So Imunon R&D is part of our, is a lead product of our TheraPlas platform. I'll talk about the platform a little bit later. What it does, it's a gene-based product that is designed to treat cancers that are localized in the peritoneal cavity or the abdominal cavity. More than 90% of ovarian cancer ends up in the abdominal cavity, and a significant portion of GI cancers also. And the death in these patients happen from the local disease, right in the cavity. So if you can get effective concentration, safe and effective concentration right here where the cancer is localized, you have a chance to impact the life of these patients. So 001 is delivered intraperitoneally. That means through a catheter into the abdominal cavity. The goal is here to have IL-12 produced locally. Remember, not systemically. That's where you get toxicity. Locally, and also for a durable time period, so that, think about this, if you inject a drug and tumor is kind of, but then the drug is gone shortly, and you come back a couple days later, a few days later, so you have to have a sustained sort of levels of IL-12 and its downstream cytokines like gamma, as Dr. Karkar mentioned, stay in that environment, local tumor environment. And that has been a problem in the past, and the approach is used that local concentration of, effective concentration of IL-12 had been a challenge. Blood levels have been a problem. So 001 gives, local levels of IL-12 without appreciable increase in blood circulation, as Dr. Kirker showed the slide. And it lasts for a week, at least, longer than that, and then you give another shot. So imagine you can keep doing this on a weekly basis. The tumor does not get a break. And also, especially in ovarian cancer, it's a very highly immunosuppressive environment. Dr. Kirker showed a very nice slide about all different kinds of immune cells that are there, but they're not doing the job. The tumor has modified them to favor tumor, obviously. But IL-12, as he said, has that ability to change that environment, turn those tumor-infiltrated lymphocytes into more tumor-killing lymphocytes and NK cells. So if you can do that over a long period of time, you have a chance to remodel the immune environment, which is immunosuppressive, to immunostimulatory, and kill the cancer. The effect of IL-12 on these immune cells are not transient, temporary. It produces long-acting T cells, NK cells. They're memory T cells that remember the tumor. So even if you stop the treatment, the effect will last longer because you have these long-acting anti-tumor cells, T cells that hang around in the body, in the tumor environment. That's really the concept behind this product, and we'll show the data if we do have that. Those properties. So this approach has not been used by other programs. So how does it work? The composition of the drug is such that it's plasmid DNA. Plasmid DNA has the gene for IL-12. Normally, recombinant protein, the gene product, the protein has been given. It has a short half-life, systemic toxicity here. The gene is put into plasmid DNA. It's a recipe for IL-12. It's not the IL-12 itself. It's the recipe for IL-12. So then when this DNA is taken up by cells, it has to get into the cell, into the nucleus, and then starts making the protein. So body is making its own protein from the recipe. You're not giving a ready-made protein, as a lot of trials people have used that. The only problem with that approach is that when you inject DNA into the body, it is destroyed rapidly. Body chops it up. So you got to have a chaperone, a guide, a delivery system to protect the DNA at the site of injection, promote its uptake into the cell, all the way into the nucleus. That's the goal of this chaperone. Just like a Sherpa takes you to the height on a mountain peak, all the terrain of those, the guide has to know. Similarly, this delivery system developed in the company from scratch. What it does, it's got three components: polyethylenamine, polyethylene glycol, and cholesterol. PI condenses the DNA into nanoparticle. One other thing about the DNA delivery is a large, fluffy molecule. It cannot get through the small pores of the cell through endocytosis. So you got to make it smaller. That's what PI does. It condenses the large, fluffy DNA into nanoparticles of size that can be taken up by cells. That's not alone sufficient. You have to keep the nanoparticle in the body for a long period of time because immune cells opsonize, clear these things. Polyethylene glycol is known to do that, protects proteins, other things. So polyethylene glycol provides the residence time of the nanoparticle for longer, and cholesterol is for uptake into the cell. We designed this for this concept, this molecule. So Imunon R&D is a DNA, formulated DNA, that's nanoparticle in size and have capability to move into the site where the action is, where it's going to make mRNA and the protein. So now I'm going to talk about the things I said. The delivery with 001 is local, durable, and you can repeatedly do that. Those are the key features, and tumor environment. So these are the data, subsequent slides that show that. This shows that in a clinical trial, the left panel is that after giving 001 IP in these patients in our first study, we collected blood and the ascites, the tumor from the local tumor environment, the tumor cells, and measured the DNA by PCR. And you can see that there's a lot more IL-12 in the ascites in the peritoneal cavity, that's where the tumor is, and very little in blood circulation. That's first thing. Okay, the distribution of the drug is local with this data. This is human clinical data. On the right side is part of the diagram, a figure that Dr. Kirker had. This shows the levels of IL-12 in patients, and you see that there's a lot more increases in ascites. That's where the tumor is versus in blood circulation. Remember, we said that you need to have IL-12 levels in the local tumor environments. You redesign the immunology, the T cells, to be able to be more effective. This shows that the levels are durable. Left panel shows that the levels last for several days. This is also a human clinical trial data. And the right panel shows that you can have repeated delivery of IL-12. You can keep injecting every week and get the rise in the IL-12 levels. Gamma is the very key downstream cytokine for IL-12 action, and you can see that you do see the production of gamma as well. So these slides show that you have a durable, at least week-long. It doesn't get into blood circulation, and you can repeatedly dose it for a long time without significant safety concern. Isn't that the requirement was for IL-12? That was a deficiency, right? Those are limitations. So this is the data, all the human data to support that our approach is different. A lot of time people ask, so when you inject into IP, there's all kinds of cells there, tumor cells, non-tumor cells. Where does these nanoparticles go? Well, IL-12 is normally made by the body cells, so it's not a scorpion toxin or something you have to put into the tumor cell. It can be taken up by tumor and non-tumor cells, make IL-12 protein, secrete into the milieu in the environment, and IL-12 does its job by binding to receptors. And here we have this, the green are the tumor cells expressing green fluorescence protein, and the reddish are the nanocomplexes, the IL-01 nanoparticle labeled with the green fluorescent dye. You can see that on the top left panel, the red particles are colocalized with tumor. That suggests that the complexes are taken up by tumor. But if you look at this one, this cell does not have green, which means it's a non-tumor cell that also has picked up a lot of nanoparticles. So it doesn't matter. You're recruiting a number of cells to be able to make IL-12, and that's where the IL-12 is coming from, both tumor and non-tumor cells. But this is a mouse data. So, of course, IL-12 is a very potent molecule, so people have tried different strategies. Recombinant protein attached with antibodies, as Dr. Kirker said, different approaches. I think the approach we have been using has some clinical data, some benefit you will see, and that some of the approaches, new one, they're not as clinically advanced, have come up in recent times, but our product is going into phase 3, so more advanced. And of course, we have shown what is really missing in recombinant protein therapy. So this is the platform. Platform is that you take DNA, could be any gene. Imunon R&D is IL-12, but it could be a growth factor, it could be something else, anti-angiogenic agent, and you combine that with the delivery system to get nanoparticles and then inject into the body so DNA is protected. So the platform is such that it's not just one product. IL-12 is what we're developing now, but this program could be expanded into other therapeutics because the delivery system is the key. Again, the delivery system could be different. If you're injecting systemically, it's a different guide you need if you're going to Amazon versus on Himalayas. So just different system because they can protect DNA at a different environment. So you have to design the system differently. So the platform has that capability. This shows the protection of DNA. What it means is that if you take the DNA or nanoparticles exposed to DNase, it's an enzyme that chops up the DNA. And this is the left panel shows you the naked DNA. If you put into the, mix it with the DNase, there's no DNA left. Enzyme is chopped up completely. But if you if you take the nanoparticles, then you can see that DNA is still protected. That's the first thing. When you inject these nanoparticles or DNA, if it's naked, unformulated, it'll be degraded soon, but the formulation protects it. So the summary of our program is that it's a TheraPlas technology, TheraPlas therapeutic plasmid. It's a gene-based approach, means the gene of the product is given protein, not the protein directly. It's for safe and effective local delivery of therapeutic protein. Because if you're giving gene, the DNA sits in the nucleus for a long period of time and keep cranking the protein, as opposed to you give ready-made protein, it decays over time and you have to give it sometime, a couple times a day, sometime it's in IL-12. The trials have been daily or, sometime one of the study twice a day. But here you're giving once every week just because the DNA is the nature. It sits there and cranks up the IL-2 for a long period of time. So we have demonstrated the benefits, clinical benefits of the technology. It has more application. Other genes can be put in, and sustained local production into tumor environment is the key to tackling tumor, because small exposures die over time is not that effective. And the T cells, the NK cells that IL-12 activates, the Imunon R&D, they have durable activity, so that still stays for a long period of time. And that probably explains the benefits we are seeing in overall survival in this study. Okay, let's see. So that's all. Thank you very much for your attention. Thank you, Stacy. I would like to have Dr. Bradley now.
Yep. So let's see. What is the forward on this, Stacy? Is it the green button? Big green button. All right. Hey, everybody. Thank you so much for asking me to speak here, and thanks for your time. I'm William Bradley. I came from Milwaukee. I've been fortunate enough to be involved with this agent for a number of different iterations and trials with some of my colleagues here, including earlier phase 1 trials and the Ovation 2 trial. And I don't do a lot of these things, but when Stacy showed us the top-line data and shared some of this, there were some things that really kind of excited me, and I thought this is actually really worth supporting and trying to get this moving on to the next levels. So what I'm going to be talking about here is summations of the Ovation 2 trial, which was a phase 2 trial utilizing Imunon 001, and some of the findings that support the development of this product onto a phase 3 trial and hopefully eventually as a standard of care agent. So the first two bulletins that you see there are both long-term and short-term benefits that are seen in the intention to treat, or ITT, population in the subjects that were on the study. And the thing I think that really, and I'll show you the Kaplan-Meier curves eventually, but the thing that kind of caught my eye, because you don't see this in ovarian cancer almost ever, is essentially a 1-year improvement in overall survival. So when I saw that, and Stacy was kind of trying to be unbiased about, well, what do you guys think of this? And I raised my hand and I'm like, am I being stupid here or what? But are these patients living a year longer? And if they are, that's really a great thing. Because we can see progression-free survival in a lot of studies, and then when we follow those patients out and you get these impressive PFSs, the Kaplan-Meiers go together on the overall survival, and the median overall survival isn't improved. So if this turns out to be a real signal, that's going to go a long way. That's going to carry a lot of interest and utilizing this agent. 11-month improvement, I kind of think of 11 months as a year, because it kind of depends on a lot of different things that that factor into this, but that's a real clinically meaningful change. That amounted to a 35% improvement in overall survival in the patients that received the study agent. That's Imunon 001, which was a hazard ratio of 0.74 in that intent to treat population. And remember that the analysis, and you'll hear more about this in an ITT population, is unbiased as to whether or not the patient actually ever received the agent or how much of the agent they received, that kind of thing. So that may make a difference as well as we get better at delivering this agent. The other thing that you're going to see as we go through this is improvements in overall survival for the patients who are exposed to PARP inhibitors. And PARP inhibitors are oral agents that are used in a number of ovarian cancer patients who either have a BRCA1 or 2 mutation in their germline, so it's something they inherited from mom or dad, or it's something that's in their cancer, or if they have something called homologous recombination deficiency, which is a ineffectual way to repair DNA breaks that the cancer may have developed in the formation of the cancer. Short-term benefits are things like progression-free survival. Hazard ratio is less than 1.79 for the patients who receive the study drug. And the other secondary endpoints are related to the surgical effort, and I'll explain a little bit more about that. And then also what's called the chemotherapy response scores, which is something our pathologists provide to us when they look at these cancers under the microscope after we take them out, and they say, boy, this cancer looks really vigorous, it's like you didn't do anything to it, or this cancer looks half dead, or this cancer looks a lot dead. So a lot of cartoons here. I'm going to give you some overview of this trial. So NACT is neoadjuvant chemotherapy, and I say to patients with ovarian cancer who come into my clinic, and if they're newly diagnosed, they haven't had any treatment for their cancer yet. So one of the things I say is that we need to decide whether or not we're going to operate on you first and then give you chemotherapy, or give you chemotherapy first and then operate on you. Those are the two tools that we have basically to fight this cancer. And the patients that we choose to give chemotherapy to first and then operate on typically have factors that make them frailer or less likely to undergo a successful operation. That is to say that they have a greater burden of disease. They might have a lot of ascites. They might be older. They might have comorbidities. So the picture I'm drawing for you here is that this population that undergoes neoadjuvant chemotherapy, like the patients on this trial, are a sicker group of patients. The trial itself enrolled up to 110 patients. There was what was called a phase 1 run-in. So when we completed Ovation 1, we were looking for a maximum tolerated dose of this agent, and we really didn't hit it. Patients tolerated the agent in the clinic, and that's something you've been hearing about. And so we said, okay, can we go up a little bit? So that was the first thing we did in Ovation 2. And then once we got to that level of 100 milligrams per meter squared, we continued to enroll patients randomized 1-to-1, so half the patients received the study agent, half the patients received chemotherapy in a standard fashion, typically carboplatin and paclitaxel, which has been the standard of care for ovarian cancer for decades. And I feel like Dr. Thacker's smiling at me because it's like we walk in circles in ovarian cancer. We've changed it, we've given it in the belly, we've done this and that, but we end up back, okay, carboplatin, paclitaxel, intravenous 6 times, let's go. So 1-to-1 randomization. Neoadjuvant chemotherapy means that they get treated 3 times typically with the chemotherapy on a Q3-week or every 3-week basis, and then 8 times they get a weekly dose of the Imunon agent. The reason they don't get it 9 times is because the first infusion, they've just had the port placed in their belly, we're letting them heal, and then they get the agent going forward after that. Primary endpoints for safety and progression-free survival. Threshold was 80 events or progressions, or 16 months, whichever was longer. The third cartoon is the patient undergoing her interval debulking surgery. It's somebody who's going to the operating room. So 3 cycles of chemotherapy. Typically, we will take patients to the operating room at that point, and she will undergo a surgery in which our effort is to try and remove all of the cancer that we can see. And as you've heard, ovarian cancer is typically an intracavitary peritoneal disease, and that's what makes this agent somewhat uniquely suited to this particular disease entity. Because this is not a cancer that necessarily goes to lymph nodes that frequently, necessarily goes to solid organs like your liver, your lung, or something like that frequently. What we see is disease that's studded all over the surface of the lining of the abdomen when we open somebody up. Secondary endpoints were overall survival, that chemotherapy response score, that surgical resection score, so you see R0, R1, R2, that refers to how successful our surgeries were. So we want our goal to be to remove all the cancer we can see. We debate on the clinical significance of that in the real world, but we know that the more disease we can get out, generally speaking, that's a population that will do better. So those are the things we're looking for. So those patients have that surgery. They have 3 treatments of chemo. They have the surgery. And then they go back and they get chemotherapy 3 more times every 3 weeks. Those 2 agents I mentioned, carboplatin and paclitaxel, and then 9 more weeks of the Imunon therapy as well, intraperitoneally. And at this point, when they complete that, they're left to our standard of care. So they're left to our best judgment as clinicians what they should receive going forward, and it's unbiased after that from the study point of view as to what the patient should receive. They're followed, they're scanned at intervals, et cetera. We want to know if they've progressed, but there is no prescription regarding next treatments. Oops. So first thing is toxicity. This was essentially a remarkably untoxic agent in the real world. Cytokine release syndrome, you've heard a lot about. We never saw this. This didn't happen to patients. I tell people that when I use immunotherapy for other diseases, it's kind of a balancing act. We're trying to rev up your immune system, but we're trying to point it at your cancer. And what we see in the real world is sometimes it gets pointed at another organ that we want to keep functioning normally, like our colons or our lungs or other things like that. And that can be catastrophic for patients. We didn't see those kind of things in this particular therapeutic trial. We saw abdominal pain when we got up to that dose of 100 milligrams per meter squared, and that was with infusion. And we developed a protocol to treat that pain prophylactically in the patients that had it, and we found that that was very successful. So patients would get infused. Presumably there's an inflammatory reaction. It hurts. But if you're able to medicate that with standard of care medications, generally you can manage that pain. There were dose reductions for some patients, but generally speaking, you could continue dose. The final thing you'll see there is an observed higher number of hematologic adverse events. That's kind of a sampling bias. So we kind of rejected that in our minds candidly, because when you're getting the study agent, the Imunon agent, you're getting it weekly, right? So you come for a blood test every week and you're getting chemotherapy, you're going to test somebody when they're at their nators or from their chemotherapy. And so we'd find that these patients were thrombocytopenic or neutropenic or whatever, but that's expected. And the patients who were on the standard of care arm who came every 3 weeks got a blood test every 3 weeks. So I found that to be a fairly uncompelling toxicity, candidly. The final one, infections related to the port. So you need a catheter to go in your belly in order to receive this. So this is a piece of rubber functionally that sits under your skin and enters your abdomen, and the agent is infused through that. And whenever you've got a foreign body in a human body, infections can occur, and this happened there. This happens with what's called metaports, or the devices that go under our skin into our big vessels. Somebody didn't wash their hands carefully enough, turns red, it comes out. You replace it if you need to, things of that nature. Outcomes. So the ITT population is 112, and I'll explain the PARP treated in a moment, but the progression-free interval, which was the primary endpoint, was 14.9 versus 11.9 months, so a 3-month improvement in progression-free survival. The study was not powered to see that difference, and it was considered a non-significant difference. You can see it does cross, hazard ratio does cross 1, but you see that trend. The next line down, or row down, is the PARP-treated patients. So of that 112 patients, 31 received a PARP inhibitor immediately upon completing chemotherapy, which is a very common medication that we utilize in ovarian cancer therapy. We saw a more dramatic response in those patients. So the median time to an event, and PARP inhibitors are supposed to help you not have a recurrence, so that's expected that median time to progression would go up, but it went up 11 months in the patients who were treated with the study agent versus the patients who received a PARP inhibitor and not had the study agent. So there may be some interaction there. I don't think we know what that is at this point, but PARP inhibitors are out there. They're FDA approved. We use them a lot, and that's a pretty impressive improvement in PFS for those patients. Overall survival, that's where we get to what I thought was the most exciting data, that those patients who received the study agent had an 11-month improvement in their overall survival. And you'll see that the PARP inhibitor treated patients, whose numbers went up, excuse me, because presumably a patient who had recurred and then was treated again and had not had a PARP inhibitor before that first recurrence, she may have received a PARP inhibitor the second time, something like that. And those patients had not even reached the median of their overall survival versus 37 months in the patients who had not received the study drug. So we have, in my mind, is interaction both in progression and overall survival, and what we see is improvement in both progression and overall survival. And as a clinician and as a clinical trialist, to me, improvement in overall survival is really motivating, because that's going to be the thing that, you know, if I look at a woman in the clinic and she has ovarian cancer and I say, I can give you this agent and you're likely to live a year longer, that's going to be something that I'm going to want to offer her if that turns out to be what we see, and that's going to be something that I think a lot of patients will accept. Next three slides are Kaplan-Meier curves that reiterate some of the same things I just shared with you, but this is what it looks like on a Kaplan-Meier curve. So this is the OS in the intent to treat population. So this is all comers. So this is the 112 patients. And you can see, I'll try to use this beamer, but it doesn't show up on the TV. So what you can see is you get to that median and you start to see that blue line, the patients who received the Imunon agent, stretching out and flatlining there. Over time, you start to see it drop again, but median PFS has been improved with a hazard ratio of 0.74 and 11-month PFS, or OS, excuse me, I said PFS, OS improvement. This is where you really start to see fairly dramatic improvement. These are the patients, again, who received PARP inhibitor. These are the all-comer PARP inhibitors, so both the ones that received it immediately upon completing chemotherapy and upon second recurrence. And remember that both sets of patients here got the PARP inhibitor. So we don't think that the PARP inhibitor itself would be driving this response, or it's not clear how that would be the case, because you think if everybody got the same drug, the lines would be overlapping. But what you see here is that the patients who received the Imunon agent seem to have a much more durable survival when they received a PARP inhibitor as well than the patients who received a PARP inhibitor alone. So again, these are agents, PARP inhibitors are out there. There's multiple approved PARP inhibitors. Patients get them for a lot of different reasons, and they seem to have some kind of interaction in the study population. Patients who didn't receive a PARP inhibitor did also benefit. Again, hazard ratio here of 0.78. The difference isn't quite as great in overall survival, but close to a year essentially. So again, quite impressive, and to my mind, as a clinical trialist, something that's really quite motivating in this population. Final slide refers to excuse me, R0 response. I mentioned that as the measure of how successful the surgery was vis-a-vis removing all of the cancer. And the blue histograms there are the Imunon receiving agents versus the red, which received chemotherapy alone. And another, about 2/3 of the patients who received the Imunon agent versus a little more than half who received chemotherapy alone had that R0 response, which is associated with complete removal of the cancer that's visible to the surgeon. So we associate that with a better outcome. And then the other one on the right, again, blue and red, you see a doubling of what's called the CRS score of 3, which is associated with the cancer looking more dead under the microscope. And so whatever's happened to the cancer, both of these populations received chemotherapy, same kinds of chemotherapy, same way, and then the blue population receives the Imunon agent, and about 1/4 plus of those cancers look exceedingly dead at the time of resection, which should be associated with a better outcome long term. So we saw both long-term benefits and overall survival, which, as I've said a couple of times, I find quite exciting and really motivated me to say yes to be here and to talk to you guys, because I would love to see that from our patients and be able to offer that to our patients. If we see this, we can imagine this agent moving on to standard of care. We also saw an interaction that was recapitulated both in progression-free survival and overall survival in terms of combination with standard of care PARP inhibitor therapy. So There may be some ways to enhance this agent, which would be wonderful. Certainly it's going to be something that we're actively interested in as this next phase gets designed. And then the final bar there shows or claims that we see an early treatment benefit, which is referring to progression-free survival. So we still see a progression-free survival improvement in this agent, especially when combined with PARP inhibitors. And then finally also surgical response, as well as pathologic response of these agents, with this agent. So we've got multiple measurable outcomes that we can hit, some of which, excuse me, patient doesn't really care what her CRS score is, but she sure cares if she lives longer. And so some of which are more clinical, some of which are more theoretical, but all of which seem to be pointing in the same direction, which, again, increases my excitement for this drug. Thank you very much.
So I use a green button, right? Okay. Thank you very much. It is a really great pleasure to attend this meeting. And this reminds me a few years back, I was asked by a biotech company to represent them in front of FDA advisory committee meeting. You know, my job was to convince the board members, say, well, this treatment from the company really shows something. So before the meeting, the client told me, say, LJ Wei, you only have 3 minutes. I said, well, gee, you know, I usually give a talk of 50 minutes, right? Then the CEO told me, say, LJ Wei, you don't understand that you stay in academic world too long. If you have a chance, talk to investor, talk to FDA folks, talk to industry folks, your 1 minute is worth $1 million. So you already get $3 million today. What do you complain about it? So today, Stacy said, LJ, you may have 15 minutes. I said, wow. You know, after this meeting, I'm going to retire. So Stacy is a wonderful person. I follow her career since she was a young lady back in Eli Lilly days. Now you see she's a big CEO. I said, gee, you know, if I knew her a long time ago, I should have worked for her, right? So Dr. Bradley gave a really wonderful talk about this trial result. This key word, consistency of the result. So if I may, to share with you, this is really not a new methodology. We put it together. I want to show you something. The data we observed from the phase 2 study is not really appear randomly. It's not random. Actually have a really strong signal. Okay. You notice when we finish the clinical trials, we have a progression-free survival, in this case, which was the primary endpoint. Secondary endpoint, OS, right? So you notice Dr. Bradley analyzed the data, look at each outcome separately. I look at the progression-free survival. I say I give you hazard ratio, give you a Kaplan-Meier curve. Then I go to the OS, then go to the response, right? Now the question is, should we combining the information across different outcomes, get a totality of evidence of a treatment effect, instead of we look at what separately outcomes, okay? So let me share with you, this methodology has been utilized very often in cardiovascular disease clinical trials. So I don't want to bother you again. This is a PFS, right? The progression-free survival. You notice your Kaplan-Meier curve. The blue line always above the brown lines. You say, wow, numerically, visually, I know there's something, there's a signal. But you notice hazard ratio 0.79, pretty impressive. But you notice the p-value is 0.29, right? You say, well, you know, 0.29 is much greater than 0.05. I know who invented 0.05, by the way. Okay, everybody get excited if you're less than 0.05. But anyway, we say, well, you know, this is some kind of signal, but maybe not very strong. Okay, so let's look at OS. OS is very similar. Your blue curve above the brown curve, and also, p-value is around 0.3. Hazard ratio is impressive. That's Dr. Bradley shared with us. Okay? Now, what are the reasons we got this moderate p-values? Of course, this is a phase 2 trial, right? You notice there were 49 deaths out of 120 patients, right? So I know you guys are experts in clinical trials. If you do the time to event analysis or survival analysis, the precision of hazard ratio depends on the number of deaths. If you don't have enough number of deaths, you're not going to go to this 0.05 p-value stuff. So this is an initial phase 2 study. We got a 49 deaths. We're actually pretty happy to get this decent p-value. That's one reason why we don't get this so-called 0.05 so far. Now, you notice hazard ratio is only valid when you have a proportional hazard assumption. If you don't understand, don't worry about it. That means they're under a strong assumption and the hazard ratio is valid. If it's not valid, hazard ratio is not a very powerful detect the difference between the two arms. In this case, the answer is yes. It's actually lack of power because lack of this model assumption. Okay? Now, important part is Dr. Bradley saying consistency. I say, wow, P of S, my treatment is better than control. For OS, my treatment is better than control, right? I say, okay, that's interesting. Can you combine those two outcomes all together in the patient level? Let's see what happened. So let me show you. This is everybody knows. This is 4 typical patients in cancer trials. We use a black dot is the death, and the red dot progression, and the circle means the censoring. Right? We don't follow the patient long enough. Now, first the patient. You notice the patient died at what? 16 months, right? Okay. I said, wow, 16 months the patient died. How about second patient? Second patient had the red dot progressed, then died. Third patient, censored. The third patient died, progression and died. The last patient survived, right? Sensor observation. So these are 4 typical patients. Consider 2 outcomes together, progression and the death. Now, then I say to myself, well, how about each patient? When the patient goes through the clinical trial, how many outcomes this patient could have? Now, remember the first patient died without a progression, right? So I said, well, on the left-hand side, on the top corner, I said, well, look at this patient. I have 1 jump because the patient died. So I have 1 jump size 1. I call this step function, go up. How about the second patient? Second patient is the patient had a progression, then censoring, right? Bless you. The third one is go up, the red curve, then black. So you notice, wow, if the curve is higher, individually means the worse, right? The patient experience too many outcomes. I said, wow, how did you summarize each individual patient's journey during the clinical trial? I said, how about area under the curve for this, each one, like a gray area? The large area means what? The patient was in trouble, right? The smaller one, the area under the curve is better. So we actually can summarize just averaging all the individual curves to have aggregated information for each group, each treatment, right? So here you are. The red curve is the control. Remember, the higher the curve means the patient experience more outcomes, bad outcomes. And the blue curve is lower, means what? Those patients experience fewer events. Well, look at this curve. The red curve is always above the blue curve. So that means aggregate between the 2 groups, my treatment is better than the control. I said, oh, how did you compare those two curves now, right? I said, well, you tell me area under the curve, the higher the worse. I said, all right, let's figure out the area under the curve. The left-hand side is 31.1, I guess, right? You know, it's very sad to be old. When you put glasses, you couldn't see very well, but without the glasses, you couldn't see very well, right? So my lesson to you guys, don't get old. So 31 months total time lost from the control patients, and 24.6 total time lost from the treatment. The fewer, the better. So the difference is 6.5 months. All right. Now let's see, because you guys worry about a p-value, right? Let's see what happened between the two curves. Do you think I made it? The p-value, right? Look at the bottom one. One side, the p-value is 0.0375. What does that mean? That means if there is no signal between the two groups in terms of progression-free or the overall survival, the chance to observe this beautiful pattern is only 0.0375. All right? So this methodology combining different outcomes to see what we observe today is not a random. It actually shows us there's a very promising signal right from this phase 2 study. This methodology has been used for many cardiovascular trials because a cardiovascular patient, you have what? Hospitalization, MI, stroke, and the CV deaths, right? So you combine all the information together. So there are two papers we published in the recent few months, few years, and if you're interested, I'd be pleasure to talk to you about. Thank you very much. Appreciate it.
Okay, so thank you everyone for the kind invitation to participate in this great event. My name is Amir Jaziri. I lead research at MD Anderson. And today I'm going to tell you a little bit about kind of what might be in the store for the future. And the second ongoing trial, which is a phase 2 trial that's randomized in patients that are receiving neoadjuvant chemotherapy for ovarian cancer with standard chemotherapy plus bevacizumab. So bevacizumab, also known as Avastin, is an anti-angiogenic drug, and we'll talk more about that. These patients receive, the randomization is based on whether they receive Imunon 001 or not, and that's the NCT number for it. This study is sponsored by Imunon and also co-founded by Breakthrough Cancer. And I'd like to set the stage a little bit about this trial because it has kind of a unique design and unique sponsorship. And so I want to tell you a little bit first about Breakthrough Cancer. So Breakthrough Cancer is a relatively new philanthropic organization. This was established through generosity of the Goodwin family. Their idea was to learn lessons that sort of we all learned from COVID to accelerate discovery in the cancer arena. And they had a very ambitious goal. So they are not just targeting ovarian cancer, but also AML, pancreatic cancer, and glioblastoma. One of the ovarian cancer projects that was finally approved to go ahead was this our study of looking at minimal residual disease in ovarian cancer, and this Imunon trial is really a flagship protocol that's part of that project. The other ambitious aspect of this is that they wanted to break down silos, so they took 5 big cancer hospitals, and they assembled investigators in these institutions to work as a single team lab, and they kind of talk about radical collaboration as a short note for this approach. So this is MD Anderson, Sloan Kettering, Johns Hopkins, Dana-Farber, and the Koch Institute of MIT. And so this graph, and so what is this MRD? What is minimal residual disease that I'm referring to? This graph shows disease burden in a typical ovarian cancer patient over time. So you can see on the left-hand side of the graph is when patients are diagnosed. And after frontline surgery and chemotherapy, you can see that the number of cancer cells in the body decline. They drop below the orange hashed line, which is meant to represent the limits of clinical detection. So this is by CT scans and CA-125. However, very few patients make it down to the cure zone, which is shown here in green. During this phase of treatment, patients are treated with maintenance therapies. You heard about PARP inhibitors, and Avastin itself, bevacizumab, is also a maintenance therapy that we use in patients with our HRD negative, homologous recombination deficiency negative. Unfortunately, for about 85% of patients, these numbers start to rise again. Cancer becomes clinically detectable. But then what happens, we still give patients the same chemo drugs. We say, well, they're still platinum sensitive, and so they get more chemotherapy. And it's only towards the right-hand side of this graph where clinical trials are introduced. And so, the idea of this minimal residual disease approach is, what if we could gain information at the time where the cancer is not clinically detectable through an operation called second-look laparoscopy or by circulating tumor DNA markers, both of which I'm going to expand on in the next few slides. But what if we could identify those patients that are high risk at that point and offer them novel therapies at that point? So that's kind of one aspect of it. And why is that important? It's important because during that phase of treatment, there is 10,000 to 100,000 fewer cancer cells in the body. And so it makes sense to attack the cancer when it's kind of on its heels rather than wait till it becomes clinically detectable again. And then if we can think of this MRD rate, or rate of positivity after frontline treatment, you can also see that as a potential surrogate marker for how well our frontline treatment is doing. So you might expect that those treatments that work better in the frontline, there should be less residual cancer left for those patients. And so I'm going to talk about that as well. So this second-look laparoscopy is an operation that's a minimally invasive surgery. So it's done through small incisions. It's an outpatient procedure. And what happens is patients that have finished their initial upfront treatment for advanced stage ovarian cancer, they undergo imaging and CA-125. And those patients that are negative, so we would otherwise call these patients in remission, then are offered this surgery. During the surgery, we do multiple systematic biopsies, and we also put in saline, and we swish that around and aspirate that fluid and send that for analysis for cancer cells as well. And if any of the biopsies or this washing is positive, then we say that that patient has surgical minimal residual disease. So that patient has evidence of residual cancer even though it's clinically undetectable. We've been doing this at MD Anderson over the last 5 or 6 years, and it also presented a time point to collect plasma with the idea that someday we might be able to get the same information from a blood test, and I'll tell you about that. And so, as you might imagine, those patients that have residual disease have worse outcomes. The graph on the left shows progression-free survival, the graph on the right, overall survival. And you can appreciate that patients that have surgical MRD positive have about a third PFS, so 7 months versus 24 months. And patients that don't have MRD in terms of overall survival live over twice as long. So that's a significant prognostic indicator. Also, it might make sense, if you have an indicator of prognosis, those factors, those clinical factors that portend worse disease should also correlate with patients that have residual disease. And this table here shows that compared to patients that have initial surgery. Those patients that are sicker or have a lot more disease burden are often treated with neoadjuvant chemotherapy, and you can see an odds ratio of 6.4 for being MRD positive. As I mentioned, patients that are HRD negative have a worse prognosis. Again, that's a significant factor. And patients whose surgery, you heard from the previous talk, that patients, we hope that all patients have R0 resection, but those patients that had residual disease that was unresectable also have worse outcomes, although the numbers of those patients were fewer, so they did not reach statistical significance. So this is all with results of surgery, but now we live in an era where we can look for tumor DNA in the bloodstream. And so circulating tumor DNA, there are a number of assays. The front-runner assay is the Signatera assay. This assay is created by taking each patient's personalized tumor and comparing tumor DNA with normal DNA. This comparison identifies certain signatures in the tumor DNA. Then assays are developed to look for these signatures, and these signatures can be looked over time in the bloodstream. And so one question was, well, how good is this circulating tumor DNA when we compare it to those patients that underwent surgery? I should mention that the Signatera test is validated as a prognostic marker for early stage disease across a number of different tumor types that are listed here on this slide. You can see that in the Kaplan-Meier's, those patients that are ctDNA negative have much better outcomes compared to those that are positive. And so this is our results. We had 44 patients that had both surgery results and ctDNA. And if you look at the column on the left-hand side, so among the 22 patients that were positive for surgical minimal residual disease, ctDNA picked up 11 of them. In the second column, you can see that of those patients that surgery determined that there was no minimal residual disease, 4 of them actually had positive ctDNA. And so this kind of points to a complementarity between these two approaches for detecting minimal residual disease. And in fact, if we look at prognosis, now this is sort of a, in those 44 patients that had both second look laparoscopy and had ctDNA results, you can see that both ways of looking for minimal residual disease had significant prognostic information, and you can see kind of the hazard ratios there shown on the bottom. And in fact, if we look at all 4 groups, so if you consider those that are both MRD negative by second look laparoscopy and ctDNA, those are the patients shown in the orange curve, so they did the best. Those patients that are positive for minimal residual disease by both surgery and ctDNA did the worst, that's the blue line. And then patients that were either positive for ctDNA, MRD by ctDNA or second look laparoscopy kind of were in the middle. And so in summary, we feel that minimal residual disease might play a role in the kind of future modern management of ovarian cancer. And some of the benefits are both as a prognostic marker. At least with surgery, we also get biopsies, so we have the possibility to look at the biology of the disease in a phase that otherwise is undetectable. We feel that this is a prime time for therapeutic intervention. Why wait till patients are more heavily treated and nothing works? And then, as I mentioned, a surrogate endpoint for frontline trials, and this is a point that I'm going to come back to with regards to the Imunon trial. You heard a very nice talk on sort of the importance of IL-12 as a cytokine that can make cold tumors hot. I won't go through all of this for time, but I will just say that there is collaboration between hypoxia signaling and VEGF pathway, which is a main hypoxia-induced vascular endothelial growth factor, and immunosuppressive factors in the tumor environment. So these abnormal blood vessels often are obstacle to T cells getting to their target. And on the other hand, immunosuppressive cells such as Tregs and M2 macrophages also secrete factors that increase angiogenic factors. And so there's really plenty of rationale for combining IL-2 with a number of different modalities. This includes standard chemotherapy, which of course the OVATION 2 trial was all about, but also to add anti-angiogenic treatment, in the case of this trial, bevacizumab, to inhibit the VEGF pathway. And maybe someday in the future there will be other sort of reason to combine with other types of immunotherapy as well. And so this brings us to the schema for the Imunon MRD neoadjuvant trial. So again, the sort of selection criteria are very similar. These are all patients with suspected stage 3 or 4 ovarian cancer that have been recommended to receive neoadjuvant chemotherapy. All patients undergo diagnostic laparoscopy. That's the first opportunity to obtain tumor tissue and closely examine the amount of disease in each patient. Patients are then randomized to either experimental arm, where they get neoadjuvant chemotherapy plus bevacizumab plus Imunon 001. That's administered intraperitoneally through a port. Or the control arm, where they get just the neoadjuvant chemotherapy and Bev. You can see that patients get at least 4 cycles of neoadjuvant therapy, and then depending on sort of clinical outcome, they may get additional cycles. But most patients will undergo interval cytoreductive surgery. This is a second opportunity to look at tumor. You heard about the chemotherapy response score, which is something that can be applied to this phase of treatment. And then patients get the second phase of adjuvant chemotherapy, again with Imunon 001 in the experimental arm. And then everybody undergoes second look laparoscopy for detection of MRD. And this, in fact, is the primary endpoint, is the rate of second look laparoscopy between these two arms. And of course, this is going to be compared to secondary endpoints, which are PFS and overall survival. And you know, there's a number of sort of innovative aspects to this trial. The first, of course, is combining anti-VEGF or bevacizumab therapy with Imunon 001. The second one is the use of an early surrogate endpoint, the MRD detection, so that we can learn as soon as each patient has finished their frontline treatment, we have information. We don't have to necessarily follow patients for PFS and OS, although that analysis will be done in parallel. And then you can see the maintenance arm. Those patients that are HRD negative or homologous recombination proficient are going to get maintenance treatment with Bev and IMN 001. Again, this wasn't done in the OVATION 2 trial, but it's a way to look and see if adding additional course of treatment can provide benefit in outcomes like PFS and OS. Now, that's fine, but what does the FDA say about things like minimal residual disease as surrogate outcomes? There is a draft guidance. This is a draft guidance. It's not finalized. It's open for comment, and those of you who are interested can look it up online. But it's for use of MRD and circulating tumor DNA for drug development. And I just copied verbatim the parts of this guidance that I felt were more relevant to this discussion. So you can see under the first subheading, ctDNA as a measure of response. And in the second bullet, FDA encourages sponsors to develop evidence regarding usefulness of ctDNA response in addition to or supporting pathologic complete response information after neoadjuvant chemotherapy. So that is precisely what second look laparoscopy tells us, is it identifies those patients that have pathologic complete response. In the second bullet, ctDNA as an early endpoint in clinical trials. Again, you see in the last bullet, trials that collect ctDNA data before and after drug treatment should also collect long-term outcome data to characterize association between ctDNA clearance and outcome, and that's certainly something that's incorporated into the Imunon MRD trial. There's a lot of additional translational research. The top figure here is meant to just show multiple time points where tumor peritoneal fluid, so remember IMN 001 is administered intraperitoneally. This also allows us to collect fluid and look and see what's happening in the peritoneal cavity over time. So we can collect serial peritoneal fluid and ascites and to do comprehensive transitional analyses. And we also hope to develop organoids and other models so that we can learn additional insights. And I just want to give you sort of a sample of what is this translational research might look like. This isn't part of the Imunon study. This will be, but this is just example of a patient vignette from retrospective study that we had done at MD Anderson, where we used 3 cutting-edge digital spatial transcriptomic platforms. One is called Geomics, another one is called Visium, and the second one looks at protein, is called Codex. And I just want to kind of go through this small vignette. On the left-hand top side, you can see the CA125 or the tumor marker graph. This was a patient that underwent standard treatment. She had biopsies initially before starting treatment at the time of interval debulking surgery, and then she also underwent a second look laparoscopy, which was positive. And this biopsy here on the top, you can see on the left-hand side the H&E stain, and then based on gene expression, we can also identify areas that are tumor and not tumor. And actually, because we have the spatial or pathologic information on the slide, we can even dig in deeper. On the right top, you can see that you can look at areas that are tumor stroma, tumor vasculature, and a lot of additional information. Now, when we looked for this patient, the difference between gene expression at the time of second look laparoscopy biopsy versus interval debulking surgery, one of the pathways that stood out was hypoxia on the left bottom, and in the middle bottom, you can see that several hypoxia-related genes, HIF1 alpha, VEGF-A, VEGF-B, and F-kappa genes, these were all higher expressed in the tumor areas. That's the areas that look yellow and bright blue on the bottom. And CA9, which is a protein marker of hypoxia, was also seen in the same areas in Codex. So you get a lot of information about what's going on directly in the tumor and its surrounding microenvironment. This is, so far, the progress with this trial. There's 9 patients that have been enrolled, and Memorial Sloan Kettering just activated this trial a couple of months ago, and Johns Hopkins is about to activate, and we're talking to other sites about opening this trial. And with that, just a conclusion slide that second look laparoscopy is safe and feasible, and it can identify patients that, of those patients that we consider to be in remission, 25 to 65% of them actually have, in fact, minimal residual disease. And while today ctDNA is not as sensitive as surgery, I think the caveat is there are several potentially more sensitive commercial assays that are now present, and we plan to look at surgery versus performance of those assays. I hope I showed you that minimal residual disease detection conveys an important prognostic information. Patients that were surgically MRD negative had 3 times longer PFS and over twice longer OS compared to those patients that were MRD positive. And then the Imunon trial will provide unprecedented clinical and translational data that will be invaluable to future development of this program. Some of the aspects of this are longitudinal changes in the tumor microenvironment and immunobiology that we will have from repeated serial sampling. We plan to look at clonal evolution of ovarian cancer, and also, importantly, correlate minimal residual disease detection and quantitation by ctDNA and second-look laparoscopy, and correlate these with PFS and OS. And with that, thank you very much.
Well, good morning. I'm Premal Thacker. I'm very pleased to see such a great turnout because I have been part of this program for over a decade, and really hope to share with you sort of summarizing everything you've heard today. You've heard a lot of great data, both preclinical as well as why is the biological importance, but also telling you more about the clinical relevance. So one of the keys is I think we should first put it into perspective about ovarian cancer in general. We know it's one of the deadliest diseases in gynecologic oncology. Over 20,000 cases it will be diagnosed in the U.S., and we'll lose over 13,000 women. To also put it in perspective, we will have about 250,000 women or more worldwide in 2022 who are diagnosed with ovarian cancer. So even though we're just talking about here and now, this is a global disease, and one of the reasons that sadly we lose so many women is because we actually diagnose these women very late. They're all diagnosed usually stage 3 or 4 because, you know, I have to give a plug out. This is Gynecologic Oncology Awareness Month for all of you. So, you know, it's an insidious disease. So what does that mean is that the symptoms are vague. They're bloating, you have a change in bowel habits. If you ask any woman sitting in this room, and as we all age, we have differences in our bodies. So we sort of ignore those issues and then find out, oh my gosh, you have an ovarian cancer. We don't have a great way to detect it in its early stages. So we find these women in this advanced stage. We also know that we lose greater than 60% of these women within 5 years. So we need to do better. So really the key is how do we sort of change the standard of care? Because really if we can diagnose women, get more effective treatments up front, and they don't recur as we're still waiting for MRD and other ways to detect, the chance to cure these women is up front. And so we need to do better. And so as Dr. Bradley alluded to, our standard has been Taxol carboplatin. So how do we get better at this? So this is really why it's such an unmet need and an urgency for us to try to improve this. And now we really have this ability. So going on, it's just to say once again that we really need to get important and better treatments. I do want to sort of also step back for a moment. When this trial was designed, PARP inhibitors were not the standard of care. So when you see us talking about maintenance today, or you're talking about looking at ovarian cancer in general, it was not part of this. As all of us who are sitting in this room know, clinical trial designs are developed with the best information at the time of developing a trial. And then we all look back. It's sort of like when you're on Sunday and you're like, I don't know which game I'm going to like, which team I'm going to root for, and on Monday you know all the answers. Well, here we are knowing about PARPs, but that's also only for a segment of the population which are HRD deficient, as well as patients who are BRCA mutated. So we have 50% of our patients who aren't really benefiting from our maintenance treatments. So we're making incremental improvements, but we still have a long way to go. So I just want to underscore that because I think sometimes people might be like, well, you know, you're talking about PARPs in a subset, but it wasn't part of this trial design. And so we've been pretty good the last 16 years. We've had lots of approvals, but these are all PARP inhibitors that you're looking at. None are immunotherapy. What are we talking about today is how do we bring in immunotherapy into our standard of care? Every day I sit in my clinic and every patient looks at me and says, where's the immunotherapy for you? Because it's not there. We've made progress in melanoma, we've made progress in lung, and these are now standards, but for the ovarian cancer patient, there is no standard. And so drug development is hard. And so I think it's also important, to say how many trials have we done that have also not hit You probably, if you watch the financial world, you guys have seen this, right? Like we keep thinking, and we always look at platinum resistant, and I'm sorry it's not animated, but it was really nice. It used to drop in everyone that was going down, but it's a PDF. But I think it really sort of hits that we keep trying. And, you know, as all of us who are in clinical drug development will tell you, the best day for us is a day that we are actually not in business anymore as an oncologist. We want to cure these women. We want to get better treatments. And as Dr. Jaziri is from MD Anderson, the cancer needs to be redded out, right? So also with our successes, we've had 6 ovarian cancer retractions over the past 2 years, right? PARP inhibitors are no longer allowed to be used in second-line treatments because there's thought to be a detriment, actually, to your overall survival if you use a PARP inhibitor in a later line of therapy as well. So I think that's important to know that even with our successes, we sort of modify them as we come around. But as I want to really emphasize is what is our track record in immunotherapy to date? Where have we been? We've actually invested thousands of women on these trials, and if you put yourself looking at sort of the middle and the bottom, what you'll see is that we've looked at multiple PD-1 and checkpoint inhibitors in combination with even bevacizumab in newly diagnosed women. So if you look at Imagine 50, which I participate in and put on patients, because as I said, every patient comes into my office wanting immunotherapy, I was like, this is great. We're going to synergize and put, you know, Avastin or a VEGF inhibitor with a checkpoint, and we're going to try to make this work. And we failed. We haven't seen a benefit in PFS. We haven't seen a benefit for these women. And I say we also thought we also had a biomarker. You're PD-L1 positive. So we all want to know, we find a biomarker and can we act on it? These women were PD-L1 positive and we still didn't see a benefit. And we keep trying to tease out the translational research to try to figure out why is it not working. Because you've seen and heard ovarian cancer should be able to be very responsive to immunotherapy. We know it's a tumor that really can benefit if we can get those T cells to come in, that we can really hopefully eradicate it. Early work has been done by Dr. Kukos and Zhang showing that if you have T cell infiltration into those tumors, those patients lived longer. But how do we wake up the immune system? It's really important, and we haven't figured that out until today, hopefully with Imunon 001. So I'm trying to tell you, how do we put this all together? Because this is the paradigm today, is really, you know, first-line treatment of taxanes, and then we know our patients sadly recur. And so when they recur, we try to still give that arbitrary definition, platinum-sensitive disease, platinum-resistant disease. I see people nodding their head because if you've been doing this long enough, that's what you've only hear. And then we try to go ahead and, you know, give patients option after option. And these women live quite a bit of time and can get through many options. But really what we want to do today is how do we get them their best life and try to cure them and get the best overall survival for these women. So really, once again, to summarize what OVATION 2 has shown is that it does show an OS improvement. You can actually see that there's a benefit for these women of about 16 months, and you had to get at least just 20% of the protocol-derived treatments and a 56% improvement in OS. Thank goodness I'm not a statistician, but you could see those curves and the reanalysis of it. They're impressive. They're all going in the right direction. Because, you know, when you look at even some of these larger trials, you always see the forest plot, and some are going a little to the left of that or a little to the right of the median. And this one is not. All of this is showing you that we really might be finally making a difference in these women with ovarian cancer with actually an immunotherapy that's helping. So once again, these are the overall survival improvements that you see, and you definitely see in the ITT population that there's an improvement in the patients who receive Imunon 001. And that's 11 months. And that was an intention to treat. So more than 50% of these women are HR proficient. The patients that don't do well, and they benefited. And so we are seeing, and you've seen the biology to say that we are hitting the tumor microenvironment. We're making a change. And that change is what's helping us sort of help the immune system learn what to recognize to hopefully sustain and keep these durable effects for these women. And it's even better in the PARP inhibitor population. And as I said, this trial was not designed with a PARP inhibitor, so it was physician's choice who decided to be put on a PARP afterwards or not. And you see that there's this synergism, which we still need to tease out more, but it's really pretty remarkable. Because if you look at the trials that have looked at PARP inhibitors, you know, they're really, if you look at SOLO-1, which has had long-standing overall survival benefit, those are for our BRCA mutated patients. I would also tell you to look at the actual patients who are treated in that trial are really all germline treated patients. There are 2 patients who only have the tumor microenvironment BRCA mutation. So they're really like a subset, because that's about 25% of the population, or depending where you are, even less where I am. Myself and Dr. Bradley always have this discussion because he seems to be in Wisconsin, where there's a lot more BRCA mutated population than where I am, just based on the ethnicity and the way it has happened. So we need to try to figure out how do we sort of help the other 80 to 85%, because not all of these patients are HRD also to the same. And if you've been following this space, it's also hard to define HRD exactly. The assays are not all the same. They can probably change if you talk to people who are really in the biological aspect of this. That, we always test them up front, but as we give them subsequent treatments, their signatures are probably changing as well, but we don't get those serial biopsies. And that's why it's so important what Dr. Jaziri's work in looking at the Imunon trial is to really get those biological samples, get those serial samples, so we really learn what's happening and changing in that tumor microenvironment with the pressures of the treatments that we're giving to date. So here, once again, is looking at, the 15.7 month improvement that you see when you at least get 20% of the protocol treatment, and that's 91% of the ITT population. So what really that also tells you is this is safe, this is tolerable, because what you've heard from the beginning of this morning was really how hard it is to really harness IL-12's effects in order to really re-educate and sort of eradicate tumors. It's like a holy grail. Like, until Dr. Folkman figured out anti-VEGF for us, we were saying we need to sort of trap and stop and strangulate the tumors so they don't get new blood supply. We've been talking about IL-12, and now we're here on this breakthrough moment of trying to actually have a molecule that can do this. And we're showing you through our data that this is actually what we've been doing. And I have to give them credit, because I was a lot younger when I started this too with them on this journey. But it takes, sometimes you had to bat many times before you get that home run. And here we are batting, and now we think we're on something that hopefully might be actually the real home run. So why do we think this is unique? It's really because of this gene-mediated technology that's working. It's recruiting the immune system of the patient to really try to overcome this challenge. We've looked at it through phase 1. We know we're increasing and upregulating some of these key cytokines like the interferon gamma. And then we're also seeing that we have durable effects. This is a treatment that we give weekly intraperitoneally to patients. We're not saying you have to come back to the clinic every other day. We're not saying you have to come back, even sometimes just a couple times a week. We're saying come back weekly. And you're also seeing that patients are having sustained sort of changes even when they're not getting all 17 doses. If you look back from the slide I showed you before, if you're getting even greater than 3 doses, you're getting a benefit. So it's telling you that there is a powerful change that we can make with even smaller doses, or sort of less doses than we anticipated. So I'm not going to go through all of the sort of powerful effects, but I do want to sort of once again mention why is this so important, because it's not just the interferon gamma. It's really causing the activation and the proliferation of both your NK cells along with your T cells, really trying to get your immune system to wake up from that immunosuppression that Dr. Anwar talked about. And also trying to, not is to change these tumors from cold into hot tumors. Anyone who knows anything about cancer biology, it's sophisticated. It's very nice of us to say cold to hot, but really it takes a lot to change a tumor microenvironment. And we've demonstrated with multiple of our serial samples that we are changing that. And also it leads into anti-angiogenesis. So it's going to be really important to see the work of Dr. Jazari's group with the combination of adding even bevacizumab with Imunon 001. Because bevacizumab has been around now for over 20 years. It has never shown an OS benefit. It has shown a PFS benefit of 4 months. That is it. It has never been able to show a sustained change in OS in ovarian cancer. And it also, this molecule helps us inhibit the immune suppression that we've seen. So the key are, once again, we're trying to really change that dysfunctional ovarian tumor microenvironment. We've tried this with checkpoint inhibitors and trying to overcome exhausted T cells. I showed you how many failed trials we've had in ovarian cancer, and we haven't been able to really make those changes. So here we have the first ability to really change those CD8 effectors and memory T cells, activate that NK cells, so both your adaptive immunology, convert your Treg cells to actually be killing T cells and giving them that memory to remember how to do that, inhibiting angiogenesis, as well as potentially promoting PARP1 activation. So I do want to go back a little bit to our phase 1 study design, which was Ovation 1, which is before all the details we've been talking about today. And this was really to find out the dose that we wanted to find out, but we also, what we did in this trial is we did get the blood samples and the peritoneal fluid samples that you saw Dr. Anwar present earlier. But really this was also just giving the actual Imunon 001 with chemotherapy neoadjuvantly to patients just before interval cytoreduction. So not giving it in the adjuvant setting like we did in Ovation 2. So they got less doses. And what is key about this is that we saw those changes immediately. These are not things that we had to wait till we did surgery and then see afterwards. So it's really important to know that these changes happen very quickly once we actually administer the medications. And this is sort of a busy slide, but it does show you exactly the decrease of the immunosuppressive biomarkers. So I want to sort of point you out to the bottom, you're facing left, of the decrease in the immunosuppressive biomarkers that we saw in these patients. Because everyone has shown you that, yes, we hit the target, it's not in your blood, it's in your ascites and the tumor microenvironment, but these are impressive changes in the actual tumor microenvironment. And these are samples from patients, and that we could actually see that we are really hitting our target. And we're increasing our CD8 to 4 ratios in the tumors themselves. So we're making these sustained changes. And I wish, we had infinite money that we could have done all of this again in Ovation 2, but we don't. But now technology is also better too, and we hope to implement that in our phase 3. So let's go and see how does this really affect patients, because it's, at the end of the day, like I said, this is all about patients. And what you will see is that these are patients who are actually treated at my institution. And neoadjuvant patients, like I mentioned, over 50% of the patients that we will see in our clinics typically actually qualify for neoadjuvant chemotherapy, mainly because they have such advanced disease, as well as the fact that they may be medically also not that well because of this disease taking such a toll on them. And so they come in ages from their early 40s to their 60s. But I just want you to also understand this is not like a small subset of the ovarian cancer population that's going to need this sort of therapy. It's becoming more and more common because the bar for us to be able to surgically remove everything is becoming much more difficult. So many of us have developed sort of the same algorithms that they do at MD Anderson, looking in with laparoscopy, getting the diagnosis at that time for that patient, At the same time, hopefully just if we can implement and put this port in. So we're also not adding burden to patients when we do this type of therapy either. So this is a 46-year-old female who was diagnosed with a stage 3C high-grade serous cancer, who has a BRCA mutation, and she gets 6 doses of carboplatin and paclitaxel, 3 neoadjuvantly and 3 after her surgical debulking, and received 14 weekly doses of Imunon 001. And so she tolerated about 82% dose intensity and was able to also be remaining on a PARP. And she had an R0 resection and a chemotherapy response score of a 3, so all good prognostic factors. And she did have some side effects, but they're all very manageable. You know, when somebody comes to me and says, what are unmanageable side effects? Those are grade 3 side effects. Those are the ones that I really have to dose modify for, or I have to do interventions like maybe a hospitalization. But these are sort of minor. So gastrointestinal, like diarrhea, nausea, vomiting, rash, neuropathy, and a lot of those are from chemotherapy because we know that taxanes are what give you the neuropathy. It's not really from the Imunon 001. And then they had some elevations in their LFTs. But if you can see that she progressed at 23.7 months, and that's not very different than what we saw in our neoadjuvant large phase 3 trials, which is like the CHORUS and the EORTC trials, where really patients' overall survival at that time was, actually overall survival was 30 months. So I'm telling you she progressed at 24 months. So there's something different there for this patient. Because we do know even if you are put on a PARP and you're BRCA mutated, doesn't mean that every one of those patients are cured. There are patients who, sadly, do progress. So I want to say that we made improvements, but even these patients need better improvements, and she's still alive and well at 61.7 months. The next patient we're going to go and look at is actually a patient who has a stage 4 high-grade serous cancer and is HRD positive and is 65 years old. So she too tolerated her chemotherapy, got her interval cytoreduction, and actually was able to get all 100% of her intraperitoneal Imunon 001, and then was put on a PARP maintenance as well. Her chemo response score was not as good. It was a 2, so not showing as good as a 3, but still she had an R0 resection. She did have some toxicity of like anemia, neutropenia, which was probably related more to the chemotherapy because as Dr. Bradley mentioned, that since we were oversampling our blood blood draws with the patients who were on the Imunon weekly, getting weekly sort of blood draws, we were noticing more changes because we would expect nadering with chemotherapy anyway. So, but when we sort of looked at it again, where they got a Q3 weeks, that went away, the myelosuppression amounts. And then had some grade 1 or 2 GI toxicities of nausea, vomiting, and diarrhea. And then some electrolyte abnormalities. The main thing that she had was fatigue, which if you talk to most patients, they are fatigued. And that's a hard thing to quantitate, but nothing that was interfering with her activities of daily living or anything that you'd say she's bedbound or can't really participate in life. And she has some grade 1 palpitations. She also progressed at 32.3 months and is alive at 54.5 months. That's really a game changer when you start saying to patients you're alive much longer, because we don't have those. We're starting to see a shift, but that shift is really being seen in our patients who are HRD or PARP, BRCA mutated. So I think the key I want to let you know is that if this really can be replicated in a phase 3, which we really do believe, and hopefully you've seen the data and what we're presenting in terms of how we're really hitting our target of this potent, cytokine, then we really do think it has profound activity. Ovarian cancer, thankfully, is leading the way. But there's lots of intraperitoneal cancers, right? We talked about colorectal, pancreatic. I mean, there's lots of opportunities. IL-12 is not just ovarian specific. But thankfully, I'm a gynonc, and I'm very excited to say that we're looking at it in GYN cancers, because usually lung, colon, everyone else, breast is first, and then they're like, oh, let's try GYN. So here we might be paving the path, just like PARP inhibitors, paving the path for the future is IL-12. that we're changing that microenvironment, we're educating the microenvironment and the sort of cancer biology to realize how do you sort of reactivate yourself and attack the cancer, that it's really safe. It has an ideal therapeutic window that we're able to actually be able to give it on a weekly basis safely to patients into their abdomen, which is where we want it to work. And that we have treated over 200 patients, and we really have not seen any sort of detrimental safety signals. We've looked at it in platinum resistant, we've looked at it in platinum sensitive, so even patients who are far sicker than the ones with neoadjuvant, and we haven't seen issues. So I think that's also really reassuring, and we're seeing an overall survival benefit. Talking to a patient and telling them that you have potentially an extra year of life, that's a whole year of birthdays, holidays, everything else. When you talk to a patient, like, say you have 3 months of a PFS, they're like, great, you got me 3 more months, that's a quarter. But a year is a whole different value. And this is, in a phase 2 that was not meant to look at OS, right? So it could be even longer that we might be able to get these women to as we start synergizing maybe other combinations as well. So I want to also let you know that it's really important that we try to advance the science for these women. It's a global disease. It's a disease that hits, I'm sure if we sat in this room, and everyone probably knows somebody who's been afflicted with ovarian cancer, even if it's a friend's friend or a mom or somebody, it's a deadly disease and needs better treatments. And hopefully today, you've seen all the data from us presenting to you, that you have realized the critical need, and really that we're here to make immunotherapy part of ovarian cancer and make it the holy grail that everyone's tried to attain but has not to date. And I want to thank you for your attention, and I really do want to sort of emphasize, as I hopefully have been emphatic with you, because it's hard to look these women every day and not be able to change their course, but now we potentially can. Thank you.
So I think this statement speaks for itself. You've been hearing from a group that has amazing experience, commitment. I have to say we have multiple people that actually traveled back from ESMO overnight. They're juggling OR time, being on call, and their commitment to patients is unparalleled. It is breathtaking for me. And we believe the future is bright. We are very excited by what we've seen and are very excited to move on to phase 3, which is the recommendation we got unilaterally from our DSMB. This dose, the design, the endpoint, the definitive endpoint being overall survival. And I would say that just listening to the biology, the mechanism, the platform, the clinical data, I found myself reflecting and really thinking that I think you almost have to be a member of the Flat Earth Society to not believe there's a breakthrough here. It's compelling, the consistency of the data, and we're excited not only for ovarian cancer, but then beyond of where this can go. So from my perspective, what I want to leave you with is what's next. So as a company, we have requested the end of phase 2 meeting with FDA. We anticipate that occurring in November before Thanksgiving. We are developing the design and the statistical analysis plan that will allow for early stopping and the ability to do interim looks to inform investments while the trial is ongoing. So we're thinking certainly from a very smart perspective for patients and investors. We have committed previously that we will start phase 3 in first quarter of next year, and we are on target. We're on track to do so. And lastly, we haven't said much from an investment perspective. This is obviously an R&D day to investors. If you're interested, so the kind of investors we're interested in, which is those that want to partner with us to have long-term impact, there is a phenomenal business opportunity here. So you've heard the description about the medical need, and when we meet medical need in a very powerful way, that tends to be a good business opportunity. But what we know from the commercial opportunity, and really estimating very conservatively based on checkpoint inhibitors, approved checkpoint inhibitors, there's a greater than a $2 billion business opportunity, commercial opportunity here. So we look forward to the follow-up discussions coming out of this. We again we're overwhelmed with the response to this day. And this will conclude our webcast. And then those of you who, we have a much larger number in the room than when we started, who fought through the traffic with the UN and road closures. I know I was getting text about that. Thank you for coming. This webcast will be available, so you're able to go back and look at the beginning. But in the room, we will grab lunch, and we'll have an opportunity for personal interaction. And again, for those on the webcast, please do. I know I've seen questions that were posted to the portal. Please do take the time, do that. We'll round back and answer questions. So thank you for your attention, and we look forward to now continuing our discussions.